Hi, this is Brian Kim. I want to share with you this case of a patient who has UGG syndrome from a one-piece IOL in the ciliary sulcus. Actually, this is a patient's second eye. In the first eye, what I was able to do is remove the lens, and the patient had a very small capsulotomy, a posterior capsulotomy. So I widened the capsulotomy and then placed a three-piece acrylic lens into the ciliary sulcus and optic captured it. And it was such an elegant and quick case. But in this case, I tried to reproduce the same thing for the second eye, and you're going to see something dramatically happens that makes it so that I can't do that procedure anymore. I get a radialization of the posterior capsule tear, and you're going to see how I manage that situation. As you can see, this is a patient's lens. This lens is in the ciliary sulcus. This patient also has RK incisions, and this lens is not something that's available in the US. This patient had surgery outside of the country. So you can see I make my incisions first on the right side and then the left side. And this is intracameral epinephrine. And you see I'm trying to tease the lens up. You can see it's a little bit stuck, and I'll go over exactly what's happening to that lens in just a minute. Fill the eye with dispersive viscoelastic. And this is a triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel, and then I enter. So right here, the lens is within the capsular bag, and I'm using the viscoelastic cannula to see if I can tease that lens up. I'm trying to visco dissect that haptic out, but you can see it's got this central hole, that kind of banana-shaped hole there, and I think that's why that part of the lens is not coming out. You can see that kind of banana-shaped hole within the haptic, and I'm using the Lester to tease it up, but it's kind of stuck inside the bag here. This is a Kim IOL exchange capsule dissector, and this is a prototype instrument, and I'm going to try to also free up the lens with this IOL dissector. And I'm pushing and pushing and trying to free it up, pushing viscoelastic as well, and mechanically trying to separate the anterior posterior capsules. And then I'm using a two-handed technique to try to get that haptic up, and I realize it's really stuck, and I'm not going to spend extra time causing any damage to the capsular bag, so I decide to amputate the haptic from the bag and just leave that piece of haptic that's adherent to that peripheral capsule. And then using a two-handed technique, using forceps and scissors, cutting that lens in half. And so far I'm feeling pretty good. I'm going to try to take these pieces out, and then I'm going to try and place that lens into the ciliary sulcus and optic capture the lens with a three-piece acrylic lens. So I'm minding my business, and I'm feeling pretty good about myself. And I'm using a two-handed technique, using two forceps, and I pull that first half of the lens out. And as I do this, look what happens. As I'm pulling the lens out, a giant glob of vitreous was under the lens, and as the glob of vitreous came out as well, it caused the posterior capsule hole, which was a small central hole, and now it radialized that hole. And so I don't have a round posterior capsule defect anymore. I have a very large radialized posterior capsule defect, and so I'm not going to be able to optic capture this lens in the ciliary sulcus. I will have to go to a plan B and not do that technique. It's unfortunate because I was able to successfully optic capture this patient's first eye with this technique, and the other lens was even more severely dislocated. But as you can tell, every case is different. And during that removal, I didn't anticipate that the vitreous would cause that. If I knew that was going to be the case, I would have pushed some dispersive viscoelastic within the posterior capsule defect first and then come out. And in retrospect, that's something I should have done and could have done. Nonetheless, hindsight is 20/20. So I'm doing a rather thorough anterior vitrectomy here. And now I have absolutely no vitreous now in the anterior chamber. And I'm going to take that second piece of lens out, twirling it 180 degrees again, and then pulling it out, protecting the cornea with the left hand forceps. So you can see that radialized tear, and at this point I'm switching gears to the Yamane. I have to inflate the eye, make sure it's nice and self-sealed now, drying the surface, and then I'm going to ink the limbus, first on the left side, and then I'm going to mark again on the right side. That first mark on the right, you have to ignore that because I wasn't quite centered there, so I remarked that right side, and now I have two marks 180 degrees apart on the limbus. This is a fixed caliper by Epsilon of no financial interests, and I'm indenting the sclera 2.5 millimeters posterior to the limbus, and then 2 millimeters adjacent on the right side, and then doing the same thing on the left side, indenting 2.5 millimeters posterior to the limbus in radial fashion, and then 2 millimeters adjacent. And then you want to dry, and then ink those indentations. Doing the same thing on the other side as well. Okay, so I make my incision to externalize the leading haptic here. And this is the paracentesis incision for the AC maintainer, the 22 gauge thin-walled AC maintainer. Indent the sclera with the back of the trocar, about 4 millimeters posterior to the limbus. I'm going to tunnel about 3 millimeters in tangential fashion towards that indentation, and then dive down. And then when I pull the trocar needle out, the trocar cannula is sitting sideways, which tells me it will hopefully self-seal. Here goes a 22 gauge thin-walled AC maintainer, and I'm going to tape it down with some steri-strips. And then I'm going to do some pars plana vitrectomy through the trocar. You want to make sure you do good vitrectomy over the area of action for the scleral needles. So on the left side and then the right side as well. I'm bending my needles. This is a 25 gauge needle mounted with some BSS, bending it in such a way that the bevel faces to the right. This is a 30 gauge thin wall needle, the right side needle. I'm bending it 9 millimeters from the tip and bending it so that the bevel is going to face towards the main incision. And this is the left side needle, bending it at the hub, making sure it faces towards the contralateral limbal incision, the bevel. This is a cartridge for the sensor lens. I'm putting some cohesive viscoelastic to fill the barrel, as well as the platform. Placing the sensor lens on the platform, making sure it's seated down, the optic is all the way down. Make sure that as I bend the wings together, the optic bends backwards concavely. The leading haptic comes out straight through the barrel, and the trailing haptic comes outside the barrel. And when I place it into the injector, the trailing haptic is sitting outside of the barrel. I advance the plunger, and then I'm ready to go. You can see the lens is coming out. Placing the 25 gauge needle through the contralateral limbal incision, placing the lens injector through the 3 millimeter incision. Both bevels are facing each other, docking the haptic on the bevel of the needle. My surgical assistant advances, and as she does this, I'm able to withdraw the 25 gauge needle, and because the haptic is inside the needle, it comes right out. I take over, make sure the optic comes out in the proper orientation, and the trailing haptic comes out facing to the right. Pushing some dispersive viscoelastic to coat the cornea and push the lens back, holding the trocar cannula with my left hand, stabbing the first mark with the 30 gauge thin wall needle, stabbing, and then turning on infusion, flattening out, tunneling 2 millimeters, and then I dive down. You saw how I did the technique. Stabbing, turning on infusion to get a nice firm globe, flattening out, tunneling 2 millimeters, and diving down. That's how I know I'm going to have a nice, sturdy scleral shelf so the lens is going to sit properly, not just at one point, but at a plane. What you saw here is I was trying to clear the capsule. I'm trying to maintain the capsule here as I place that needle into the eye. And you can see how easily I was able to dock the trailing haptic onto the bevel of the needle and advance the haptic into the needle. Very easy technique right there. Disengaging the needle from the syringe. using microforceps to internalize the leading haptic now. Grasping the contralateral limbal incision, stabbing that first mark with the needle, stabbing the conjunctiva and sclera, flattening it out, turning on infusion, tunneling 2 millimeters, and then diving down. Now you're going to see something when I get done with this. Something happened when I advanced that needle through the sclera on this left side. And I'll explain more in just a second. So again, I cleared the capsule using the forceps, cleared the capsule with the needle with the assistance of that forceps. And then I'm going to grasp the haptic, dock the haptic on the bevel of the needle, and it dives right in. It goes right in really quick on this case. I'm going to pull both needles out, but just shy of taking it out all the way. And then I'm going to pull the left side needle all the way out, but making sure I limit how much of that needle comes out using the microforceps. Drying the surface, turning off infusion, drying the surface so that I can cauterize the tip. Sometimes the cautery is a little bit finicky, so I'm just grabbing again. Get a nice small flange. You can see here, nice flat approach to that left side haptic. So you see that that was executed well. Nice flat, I have good scleral support. Pulling the right side now. But again, as I pull the needle out, limiting how much that haptic comes out, holding the haptic, drying the haptic, and then cauterizing the tip to get the flange. Okay, so I get a nice flat approach. You can see both haptics are nice and flat, which means I have a nice scleral shelf. As I push the haptics flush to the sclera, but as you can see now that the lens is slightly decentered. And why is that? The lens has great position from an anterior-posterior perspective. It's not tilted at all, but it's decentered. And I'm going to go over why that is. I'm trying to center it and see maybe if it caught on some capsule or something like that. And it's not caught on capsule, but what you'll see here is this. As I advance, when you go back to the case, look here. As I try to tunnel through the sclera, you can see there's a little loss of resistance because as I was tunneling through the sclera, I think it slipped through and cut through some scleral tissue. And as it cut through the scleral tissue, you see that as I was advancing the needle, you could see right there, it actually ripped through some scleral fibers. And so it didn't go through that full scleral shelf that I was anticipating. Maybe I went a little bit too far, maybe further than 2 millimeters as I was tunneling through the sclera. And sometimes if you go too far, especially in these eyes, which are very thin sclera, again, this patient had RK, sometimes as you're passing that needle and then you're trying to dive down, it strips some of that sclera and you lose a little bit of that support. But the good news is I did have a nice scleral shelf, as you saw at the end of the case. So now if you go back and look, with that haptic sticking up, the lens is perfectly centered. I just decided to amputate that excess piece of haptic, drying off the surface again of the haptic, and then cauterizing the tip. Again, it wasn't tilted, it was just shifted, decentered and shifted in a horizontal plane. I felt very confident from a refractive perspective it would be well centered. And so just amputating that piece of haptic, getting it nice and centered, and because I had a nice scleral shelf and the haptics were laying nice and flat to the sclera on both sides, I felt this was an appropriate strategy into getting the lens centered by just amputating that left side haptic. Going in and doing some more vitrectomy, you can see this patient just has a little bit of a dirty anterior vitreous space. So I'm just going in and doing some more vitrectomy. Again, you can see that radialized posterior capsule defect. Again, the capsule is underneath the lens. I did that on purpose. Providing that support, I do feel like having and retaining the capsular bag and the support in that way does provide some good anterior posterior support for the lens. It's similar to having a sulcus supporting the lens. I have that lens, even though it's a scleral fixated lens, providing that circumferential capsule support I think is advantageous. And this is the surgical PI with the vitrector. With the port down, you make a nice small hole, and you don't want to go all the way out to the angle and risk getting ciliary body bleeding. you just make a small little hole right there. You can see again the lens is nice and centered now, and with the haptics nice and flush to the sclera and very stable here. So I go ahead and place a 10-0 nylon suture to close the main incision. And then also, again, because this is a post-RK, this left side paracentesis incision was rather short because the patient also had an AK in that area. And so I had to close that paracentesis incision as well as bury the knots here. And I'll go ahead and inject some intracameral triamcinolone here, and then perform some anterior vitrectomy through the limbal incision, just making sure that there's no vitreous in the anterior chamber. Again, I did quite a bit of vitrectomy early on in the case. I don't anticipate any vitreous here, but as a final step, go ahead and put some intracameral triamcinolone. So I'm essentially done with the case. This patient had UGG syndrome with this lens, a single piece acrylic lens in the ciliary sulcus. This patient's first eye, it was rather decentered. The lens was actually sunsetted down. I took that lens out and I was able to perform a posterior capsulorhexis and then put the lens in the ciliary sulcus and optic capture it. In this case, as I took that lens piece out, that left side piece, there was some vitreous tagging along, and as I pulled that lens out, amazingly that vitreous caused that posterior capsulotomy to propagate and radialize, and so I was not able to do that technique. I quickly pivoted, closed all my incisions, placed a pars plana trocar, did pars plana vitrectomy, got that second piece out, and then proceeded with the Yamane technique, utilizing my trailing haptic first technique, externalizing the leading haptic through a contralateral limbal incision, using a 25 gauge needle passive docking technique so they don't cause any damage to the lens. I always use the Sensar lens now. It is my go-to lens, and I have very good results with this technique. But you notice as I placed that needle through the sclera on the left side, I had a little bit of slippage of the haptic through the sclera as I was tunneling it, and therefore I lost a little bit of shelf. But again, I retained good amount of shelf because the haptic laid nice and flat, but I lost a little bit of shelf, and it translated and manifested through a decentered lens, right? The lens was decentered to the right of the screen, and so I had to decide, am I going to take it out, do it again, or what? But as I noticed, if I externalized that haptic a little bit, it centered perfectly. So I decided just to amputate some of that left side haptic, trimmed it, and then cauterized the tip, and I ended up with a really nice, well-centered lens. Again, from an anterior-posterior perspective, nice and stable. I have retained the capsular bag and a nice capsular support underneath the lens, and this patient did really well in this context of having to switch gears, doing Yamane technique, and then again a decentered lens, and then trimming that haptic in order to center it better. So I hope this was helpful to you, and I thank you for your attention.